Quantitative and Qualitative Study of Borderline Personality Disorder and Partial Emotional Recovery. Number 1425, VMT Sharp 746, TDA Sharp 029, November 7, 2025. Gerald C. EclaireMD Foundation. Category: Psychology. Preface. For 9 years, from 2002 to 2010, I self-studied abnormal psychology and personality disorders, while caring for more than 250 abandoned children and abused teenagers and women under one of my charitable organizations. During that period, I read about 200 textbooks and around 300 published papers. I also began developing my medical AI software tool, which later became ready for installation on the iPhone after 2007 and on Android phones after 2008. These unique experiences gave me a close and compassionate view of how emotional wounds form early in life, how they persist into adulthood, and how partial recovery becomes possible when stability and support return. This paper is my attempt to connect these psychological observations with my long-term quantitative research and decades of work in various AI industries and engineering applications. After 2010, I shifted my focus to internal medicine, especially endocrinology, and have since written more than 1,400 medical research papers, including about 50 papers in psychology-related areas. At the end of 2020, my MIT mentor, Professor Norman Jones, encouraged me to apply the viscoplastic energy method to my medical research, which led to about 750 papers using the viscoplastic medicine theory, VMT, approach. After my first stroke on June 21, 2025, my cognitive awareness suddenly sharpened, bringing back topology knowledge I studied in 1967, 58 years earlier. Over the past 2 months, I have produced about 30 medical research papers, applying topology concept to various medicine subjects. All of the above experiences form the foundation and reasoning behind this psychology paper, where I use quantitative tools to study the highly subjective and descriptive subject of borderline personality disorders, BPD. Introduction. During my 16 years of self-directed medical research, I have learned that physical diseases are often easier to quantify than emotional disorders. Glucose and blood pressure give clear numbers, but human emotions rarely do. Borderline personality disorder, BPD, is especially complex. It sits at the intersection of biology, psychology, lived experience, and the social science of human behavior and emotional pain. It involves identity development, childhood attachment patterns, fear of abandonment, emotional reactivity, rapid mood shifts, and chronic doubt about self-worth. I write this paper not as a psychiatrist, but as a lifelong learner who studies how human suffering and healing unfold. Understanding BPD helps us see that the human mind can be fragile, deeply sensitive, and yet remarkably resilient. What is BPD? Borderline personality disorder is characterized by instability in emotions, behavior, relationships, and self-image. Individuals with BPD often feel emotions with exceptional intensity. A small event can trigger a surge of sadness, anger, or fear, and often a combination of all of these at once. Emotional states can shift rapidly from connection to emptiness, from warmth to hostility, or from hope to despair. The term first emerged when clinicians saw patients whose symptoms seemed to fall between neurosis and psychosis. Today we understand BPD as a distinct emotional regulation disorder. It affects about 1 to 2% of the population, and occurs in both men and women. In clinical and statistical records, however, women are diagnosed more frequently than men, partly due to differences in help-seeking behavior, clinical attention, and diagnostic patterns. Even though the underlying prevalence may be similar across genders, people with BPD are not morally weak or undisciplined. They live with an emotional system that reacts faster, stronger, more intensely, and for a longer duration than most minds can comfortably manage. This condition hurts the patients themselves and also affects the feelings and relationships of the people around them, particularly their loved ones, sometimes creating a vicious cycle of emotional reactions. Core BPD symptoms. The hallmark of BPD is emotional dysregulation. Common symptoms include intense fear of rejection or abandonment, unstable or shifting self-image, impulsive or self-defeating behaviors, stormy and short-lived relationships, feelings of chronic emptiness, self-harm thoughts, and sometimes actual self-harm during crises, sudden anger, rage, or emotional storms, dissociation or brief paranoia under stress, more difficulty in establishing and maintaining long-term relationships. These BPD patterns arise from early emotional injuries, especially during childhood, not from personal choice. This is why I believe the most important security blanket for any child is unconditional love and consistent care. Possible causes of BPD. The origins of BPD are multifactorial. Genetic factors play a role, but childhood experiences such as trauma, neglect, abandonment, emotional invalidation, disrupted confidence building, or sudden loss shape the emotional foundation. Brain imaging shows functional differences in regions responsible for fear, impulse, control, and emotional regulation. In my own psychological studies, I discovered striking parallels between emotional trauma and chronic physical stress. Both alter the underlying system in long-lasting ways. Both can be partially reversed when stability, safety, and consistent support return. Psychological damage, much like chronic metabolic injuries that lead to organ complications, can be partially but never fully recovered or restored to its original shape. These conditions reflect the deep involvement of the brain and neural systems, expressed through different patterns and pathways. Unfortunately, modern medicine often separates neuroscience and psychology into two distinct academic fields, even though they describe different dimensions of the same system. Stanford University has an ongoing neuropsychology research program, but I have not yet been able to learn its full content, even though I am scheduled to participate in their study beginning in March of 2026. Healing and treatment. The most effective treatment for BPD is psychotherapy. Dialectical behavior therapy, DBT, teaches emotional regulation, distress tolerance, and interpersonal skills. Cognitive and schema therapies are also helpful. Similar to chronic metabolic disorders, psychological medications may reduce certain associated symptoms, but do not fundamentally cure the disorder. Recovery is slow and partial. Many individuals improve significantly but do not erase early injuries. Like chronic physical diseases, the emotional system retains some permanent change, yet can still regain stability, functionality, and dignity. In engineering, we call this plasticity. The system can recover partially but never completely, and the recovery process dissipates some internal energy along the way. Transition to quantitative analysis using VMT model. Analysis data preparation. My first step was to create a synthesized, hypothetical BPD patient based on knowledge drawn from former patients in my charitable program and other individuals I have known who suffered from BPD. To protect identities and confidential information, I will present the case as if it were my own and use the first-person voice throughout this paper. I then set up a 30-year longitudinal timeline, consisting of 15 periods, with each period covering 2 consecutive years. This biannual structure is appropriate, because psychological change or recovery requires time, and does not shift meaningfully within a single year or a few months, even though a BPD patient may experience mood swings within hours or minutes. For the output strain, I defined a BPD severity proxy, BPD-SP, to represent the overall state of emotional, mental, and psychological condition. I adopted the biomedical convention in which higher values indicate worse status and lower values indicate better status. In this scale, 100 represents the worst possible state, while 0 represents the best or normal and healthy state. Conceptually, BPD severity can be quantified with a simple index. BPD severity is episode frequency times episode amplitude. BPD severity is equal to episode frequency multiplied by episode amplitude. Frequency reflects how often emotional dysregulation occurs, and amplitude reflects the intensity of each episode. Their product represents the cumulative emotional burden. Low frequency but extreme episodes, as well as high frequency but moderate episodes, can both generate high overall BPD severity, which agrees with clinical observation. This structure is identical to my viscoplastic medicine theory, VMT, and simple glucose energy, SGE, models. Frequency represents repeated stress loading, amplitude represents strain, magnitude, and their product approximates cumulative damage over time. Regarding the influential factors or input stressors, I selected 3 stressors that directly affect long-term psychological fluctuations and mental health recovery. 1. Therapist consultation, therapy. 2. Partner love, companionship, and support, partner. 3. The emotional impact of children growing up, which brings both happiness and frustration, children. To identify a clear pattern for BPD therapy by professional psychotherapists, I deliberately assigned 4 periods, covering 8 years from period 8 through period 11, from 2009 to 2014. During this span, I attended weekly psychotherapy sessions, each lasting 1 hour. During crisis periods, I sometimes required multiple sessions per week. In the other years, I still had occasional consultations, and relied heavily on self-reading of psychotherapy books and published papers. The partner trajectory showed an ups and downs pattern that depended on the partner's own mood, level of understanding or frustration, warmth, care, and job-related stresses. Children generated both happiness and frustration, as they moved through different stages of their growth. In summary, all 3 inputs showed their own characteristic fluctuations, but therapy was the most stable and consistently positive influence, and its impact during those 4 periods was especially clear. Partner and children each displayed their own oscillatory trajectories. A special note should be made that the childhood build-up phase of BPD, which often begins with a lack of parental love or attention, and a diminished sense of safety, is not modeled here. These belong to the pre-period years, from birth to age 20, when BPD was forming. This paper focuses only on the adult recovery era. Emotional injuries formed in childhood behave, much like physiological organ damage, long-lasting, non-linear, and only partially reversible even under the best conditions. Psychological research work. To study this objectively, I applied two scientific research methods: viscoplastic medicine theory, VMT, to analyze cumulative emotional burden and identify dominant stressors; topological data analysis, TDA, to evaluate geometric shape and directional changes across 3 decades. Although the scoring of the strain, BPD-SP, and the 3 stressors is not absolutely precise, it is at least quantitative. These two research methods provide an objective backbone for understanding BPD. Beyond subjective impressions found in today's psychology literature, they allow me to trace long-term evolution of emotional stability, shifts in the influence of multiple inputs, and the extent of partial recovery during adulthood. All numerical details and internal calculations remain inside the VMT and TDA engines, which I developed and loaded on my iPhone device. This paper presents only the macro-level findings, phase transitions, instability versus stabilization patterns, and how major adult life decisions can affect long-term emotional trajectories and BPD recovery process. VMT results. There are 2 major findings from this BPD-VMT energy analysis. First, the VMT energy contribution ratios from these 3 selected inputs are: partner is 33.82%, therapy is 33.12%, children is 33.06%. Given that these 3 inputs each follow their own trajectories over 15 periods, their contributions are almost equal. However, therapy occurred only during 4 periods, while partner and children exerted daily, lifelong influences. This contrast shows that psychological therapy's impact is highly effective and important, despite its shorter duration. Second, the cumulative VMT energy trajectory reached 88% in period 11, from 2015 to 2016, and 94% in period 12, from 2017 to 2018. This indicates that my BPD state entered a stabilized phase around from 2015 to 2018. After decades of support from my therapist, partner, and children. Partners and children can function as double-edged swords, either supporting recovery or worsening the condition depending on circumstances. However, psychological therapy consistently provides benefit. TDA results. Topological data analysis, TDA, examines the geometric evolution of my emotional system across the 30-year, 15-period dataset, while VMT focuses on cumulative emotional energy. TDA analyzes the geometric shape changes, data points, connectivity and continuity, and directional shifts of the underlying psychological space, defined by BPD-SP and the 3 input stressors. Even though these stressors are qualitative, their normalized scores form a meaningful multidimensional manifold that reveals long-term emotional transitions. Each period becomes a point in a 4-dimensional space. The geometry of these points forms a trajectory showing how the emotional system moved across time. This movement can be interpreted through 3 principal directions: PC1, PC2, and PC3. PC1 reflects the dominant emotional trend. PC1 shows a clear downward contraction from extremely high instability in periods 1 through 7 toward a more stable emotional state after period 10. This matches the cumulative VMT curve, a long turbulent phase, an inflection around periods 9 to 11, and gradual stabilization. PC1 captures the primary recovery pathway. PC2 represents compensatory or opposing influences. Therapy pulls the emotional state downward toward recovery. Partner and children create oscillations in PC2 corresponding to contribution, conflict, frustration, emotional connection and disconnection. PC2 shows multiple small reversals, typical for BPD. Over time, PC2 contracts, showing reduced volatility and greater internal regulation after period 11. When marriage became more stable, and children grew older and more mature, PC3 captures subtle and short-term fluctuations, including minor daily emotional swings and temporary stresses. PC3 remains moderately noisy, reflecting residual BPD traits that persist even during recovery. The important finding is that PC3 does not expand later in life. This supports the VMT conclusion that my emotional system reached a stable zone after from 2015 to 2018. In addition, in the selective radar chart, we can clearly see the geometric area contracting from the largest triangular shape in period 1 through period 11 to the smallest triangular shape in period 15. Viewed together, the manifold shows clear topological contraction, a wide, unstable region in early years collapsing into a narrower, smoother, and more continuous region in later years. This geometric contraction signals stabilization, similar to patterns observed in metabolic disease, cardiovascular energy systems, dental recovery, and even stroke recovery. The transition occurs between periods 9, 2011, and 11, 2016. Before period 9, the manifold shows large gaps and irregularity. After period 11, it becomes smooth and directional, clustering around a stable fixed zone. This aligns with the VMT stabilization window of from 2015 to 2018. Summary of findings from both VMT and TDA analyses. The TDA results confirm the VMT conclusions. The emotional system moved through decades of high instability, reached an inflection point around from 2009 to 2014, during intensive therapy, and then contracted into a stabilized geometric shape after 2015. Emotional recovery in BPD is nonlinear, irreversible, and partially recoverable, but long-term stability is achievable when sustained support, therapy, and meaningful life roles shape the system over time. Reflection: BPD is not a personal failure, it is an emotional injury rooted in early life experiences. In many cases, this injury arises from parental emotional unavailability, inconsistent caregiving, or early relational trauma. People with BPD often possess extraordinary sensitivity and empathy, but these strengths become painful when overshadowed by instability. When emotional regulation improves, deep perceptiveness becomes a resource rather than a burden. Studying BPD through both psychological insights and quantitative models reinforces a lesson I learned from chronic disease research: healing is rarely absolute, but meaningful improvement is always possible. As the author of this BPD research paper, I am genuinely surprised by how close the key findings are when using both viscoplastic energy analysis and topological geometry analysis. Both methods illustrate an abstract and traditionally non-quantitative subject with clarity and vividness. My personal realization is that science is truly powerful. If we were able to send human beings to the moon and bring them home safely as early as 1969, then applying scientific principles to understand emotional disorders should not be considered impossible. Disclaimer: I write this paper not for fame, but to share what I have learned so others can understand their health, prevent disease, and live longer, healthier lives. This content is provided for educational reference only, and does not constitute medical advice. No doctor-patient relationship is created. You may share this summary freely, but it must not be altered, edited, or republished as your own. All intellectual property rights and copyrights for this article and its related materials belong to the author, Gerald C.